Good evening.
I am Dr. Itkar. I am a practicing pediatrician in Kalyan, that is suburb of Mumbai. Good evening, Dr. Kiran also.
Good evening.
I'm going to, after two nice presentation of clinical presentation, I'm going more of a theoretical topic, that is alveolar arterial oxygen difference, that is ADO2, which is a very important parameter to decide about the ventilation and perfusion status of a baby. So, so many times we see this value in our blood gases, but we really so many people may not be knowing how it is really derived. So, this talk is more of a concept forming talk. I wish to have a little more discussion about this, and I wish to have this as a more of an interactive session rather than monologue. Please keep your pencil, paper, and calculator ready for some calculation which I would like to give for you. These are some abbreviation. That is, FiO2 is a fraction of inspired oxygen. PaO2, that is A is to small a, stands for the partial pressure of oxygen in arteries, and PiO2, that is the pressure of oxygen in inspired air. We all know that composition of dry air, it is 78% of nitrogen and 21% of oxygen. And these gases exert a proportionate pressure in air. See, at sea level, we have a pressure of a 760 mmHg, that is a routine barometric pressure at a sea level. So nitrogen exerts 78% of pressure in that is a 592 mmHg. And our main concern is regarding oxygen, that is 21%. So oxygen exerts 21% of a 760 mmHg. So it is approximately 160 mmHg is a partial pressure of oxygen in routine air, dry air. Whenever it comes to routine air, there is some water vapor pressure. So it reduces little bit. So the oxygen pressure reduces little bit in that. Percentage of oxygen remains constant throughout the breathable air. So that is 21% of air, that is FiO2, remains same at all atmospheric pressure. That means at a sea level, whenever the barometric pressure is 760 mmHg, it's going to be at 21%. And even whenever we are going higher and higher up, the barometric pressure will reduce, but oxygen FiO2 remains the same. That density of air goes on reducing, but the percentage remains the same. So here we have at a 760 mmHg, that is at sea level, is a barometric pressure, and the PO2 at that level is a 160 mmHg. If we go to a Kathmandu, barometric pressure will drop to a 640 mmHg and PO2 will drop to a 134, that is 21% of barometric pressure. And as we go higher and higher up, that is at Everest summit, barometric pressure may be a 253, but proportionate PO2 will be a 52 mmHg, that is 21%. Another concept is that average airway pressure in our airways is same as that of atmospheric pressure. So if we are going higher and higher up, our barometric pressure falls. So even our airway pressure goes on falling. So at Mumbai Recent, we'll have a barometric pressure, this airway pressure of a 760 mmHg. Kathmandu will have proportionately drop. And as we go and high up, our airway pressure will go on reducing. So this is small question for everybody. Anybody can answer this. If we are going high up with a air balloon, hot air balloon at a 5,000 feet above sea level, what will be the following values? What will happen to barometric pressure? Whether anybody can answer? So
pick up or type in the chat box.
Barometric pressure will fall. As we discussed before, FiO2 will remain the same, because at all the barometric pressure at higher up also FiO2 remains the same, and PaO2, that is alveolar oxygen pressure, will reduce because it goes in hand with the barometric pressure, and your average airway pressure will also reduce because it goes hand in hand with the barometric pressure. Whenever we are breathing fresh air, oxygen is 21% and nitrogen is 78%, and carbon dioxide practically it's zero. But in exhaled air, oxygen is 17% and carbon dioxide is approximately 4%, and nitrogen remains the same 78%. So what it means is that nitrogen is an inert gas. It doesn't take part in a gas exchange. So whatever the gas exchange happens is mainly from oxygen and carbon dioxide. Exchange of carbon dioxide and oxygen takes place through the alveolar capillary membranes by passive diffusion. That means it happens from the higher pressure to a lower pressure. So alveoli is having a higher pressure of oxygen, so it diffuses through a membrane to a capillaries, and capillaries are having a higher pressure of carbon dioxide. It diffuses from the capillary to the alveoli. Oxygen enters pulmonary capillary by diffusion. Diffusion happens only from higher gradient to lower gradient. So alveolar PO2 is a major determinant of arterial PO2. By same reasoning, alveolar PaO2, that is PA capital, that is PaO2, defines the upper limit of arterial PO2. It can't happen that arterial PO2 is higher than alveolar PO2. In ideal lung, whenever all alveoli and are ventilated and perfused, arterial and alveolar PO2 will remain the same, but it never happens. So the actual difference between the calculated alveolar PO2 and measured arterial PO2 depends on the several factors. The most important of these is the relationship between the ventilation and perfusion of millions of alveolar capillary units. This is a very important equation that is called as the alveolar gas equation. Whenever we are breathing air, that is a pressure of oxygen in inspired air, that depends on the FiO2 in that air. So pressure of oxygen in inspired air is calculated by FiO2 into barometric pressure. In routine air, our barometric pressure 760 is a pressure, but out of which there is some part of a water vapor pressure. So in practically dry air pressure is around 713. So whatever the pressure of oxygen in inspired air depends upon the FiO2 multiplied by 713. When this same air enters in alveoli, it gets mixed with a carbon dioxide which is residual in a alveoli. So oxygen pressure in alveoli will get reduced due to the carbon dioxide. So the formula or equation for the alveolar gas pressure is a PiO2 minus 1.2 into PaCO2. So as FiO2 goes on increasing, alveolar PaO2 goes on increasing. And as PaCO2 goes on increasing, alveolar PO2 is going to reduce. So this is the alveolar gas exchange. PaO2, that is alveolar PaO2, is equal to PiO2, that is the pressure of oxygen in inspired air, minus 1.2 into PaCO2. Here, 1.2 is a respiratory quotient. This is a constant at every place. If our FiO2 keeps on increasing at becomes a 0. Following will not reduce the alveolar PO2. So, anybody would like to respond for this? So, increase in altitude is going to reduce the barometric pressure, and reducing barometric pressure is going to reduce the alveolar PO2. Elevated PaCO2 again is going to reduce the alveolar PO2. Increase in venous admixture, that happens beyond alveolar capillary units. So increase in venous admixture will not affect anything on alveolar PO. Similarly, which of the following will not raise the alveolar PO2? This is with the same analogy. Decrease in venous admixture is not going to affect on alveolar PO2. Now we have some calculations here. At a sea level, our barometric pressure is 760. FiO2 is 21%. So 760 minus water vapor pressure is a 47. So 713 multiplied by FiO2 is a 21%. That is 21 divided by 100. Anybody can start calculating that 0.21. That becomes a PaCO2 is 40. Alveolar pressure of oxygen is a 150 minus 48, that is 1.2 into PaCO2, that is going to be 102. So in routine cases, whenever we are breathing a normal air, our alveolar PaCO2 is approximately 102. In similar way, whenever we are calculating it for our Kathmandu recent, so barometric pressure is going to reduce. So everything is going to reduce. So alveolar PaO2 will reduce in a similar proportion. So these are the calculation of a alveolar PaO2. For a Kathmandu recent, it will reduce to 83. If we are traveling to average base camp, tracker will have a PaO2 of a 33 and similar thing. Now coming further, what is alveolar PaO2 at a sea level in following circumstances? Anybody can calculate this. Anybody would like to calculate this and get back to me? Here, first example is a FiO2 is 1 and PaCO2 is 30. So, 713, that is 713 is our barometric pressure into 1 minus PaCO2 into 1.3, that is 36. So, here alveolar PaO2 is 677, which is very high. Another example is a FiO2 is 0.21. So 713 multiplied by 0.21 minus 1.2 into PaCO2, that is 60. So in this case, second example, alveolar PaO2 is going to be 89. So what is the AADO2 is a difference between alveolar PaO2 and arterial PaO2. So alveolar, we have pointed out that arterial PaO2 should be always lower than alveolar PaO2. Difference between these two PaO2 values depends on the several factors, particularly distribution of ventilation, perfusion of millions of alveoli. Oxygen and carbon dioxide diffuse across the alveolar capillary membrane because respective difference in pressures. Diffusion of either gas is so rapid and efficient that lung disease manifested by diffusion barrier does not cause significant hypoxia in a resting phase. This is our routine diagram of a ventilation and perfusion. This central alveoli is well ventilated and well perfused. So their ventilation perfusion is a matching in a properly. But another one here, alveoli is blocked. So that means it's not ventilated properly, but perfused well. But so the ventilation perfusion is going to be a mismatch here. In third alveoli, where it is alveoli is ventilated, but it is not properly perfused. So this is a dead space ventilation. So here also it is not ventilation perfusion is not matching. So if there is no VQ mismatch, alveolar and arterial oxygen difference will be almost zero, but which never happens. In normal conditions, a normal healthy person will have 5 to 10 mm normal AADO2. But as age advances, this goes on increase. Now, if anybody wants to calculate this, this example I have taken from adult text. 7-year female brought with a pleuritic chest pain. She has been taking birth control pills. Her chest X-ray was normal. And see this ABG, pH of 7.45, PCO2 of 31, PaO2 of 83, and HCO3 of 21. Just by seeing this ABG, anybody may say this is a normal variant and just pass it on. But after a few hours, this lady deteriorated. So we will just calculate how was the AADO2 in this condition. So PiO2 first is a calculating PiO2, that is pressure of oxygen in a inspired air. So pressure was of oxygen in inspired air. She was on a room air, that was a 0.21 was a FiO2. So 0.21 multiplied by 713. So this is a 149, that is approximately 150 is a PiO2. And what will be the PaO2, that is alveolar PaO2, is a 150 minus 1.2 into PaCO2, that is 31. So 150 minus 1.2 into 31, that is 37. So this is 113. So alveolar PaO2 is going to be 113. And what is the arterial PaO2? Is a 83. So the difference between these two PaO2s is 30. So AADO2 in this condition is a 30. This is a significantly weak mismatch. This was the impending respiratory failure which was happening. If we would have calculated at that time, this lady would not have deteriorated. So this is just to say that one cannot assess a arterial PaO2 without knowing barometric pressure, FiO2 and PaCO2. In clinical conditions, our barometric pressures are going to be the constant. So we do not need to bother about that. but FiO2 and PaCO2 are the variables which we need to keep in mind. Now, calculate ADO2 at a sea level, that where the PaCO2 is 40, PaO2 is 350, and FiO2 is 80%. So anybody would like to calculate this? So 713, that is the barometric pressure, into 0.8 of FiO2. So this is a 570 minus PaCO2 of 40, that is for 1.2 into PaCO2 is 48, and minus PaO2 of 350. So in this case, ADO2 is 172, which is a very high ADO. This is a bad prognosis. There are other than ADO2, there are some more indices which indicates the hypoxemia. One of that is a PaO2 divided upon a FiO2 ratio. In routine circumstances, our PaO2 is 100 and FiO2 is 0.21. So the ratio is 480. So this is approximately a normal ratio. Less than 300 indicates the severe defect. But ADO2 is a better indices than this PaO2 by FiO2 ratio. A baby breathing room air, and if we see the PaO2 of 55, we know obviously there is a problem. But if baby is breathing supplemental oxygen and PaO2 is 100, it is very difficult to judge the VQ mismatch. So VQ mismatch cannot be determined unless you know the FiO2 and PaCO. In other words, we cannot analyze the PaO2 unless we know FiO2 and PaCO. Thank you so much. Recently, I participated in a London marathon, full marathon, 42 kilometers. So this is this was a photo at that time. Thank you.
Wow, that's great. Congratulations. I think I saw Anand was with you, right? Anand Bedekar also was with you, I think.
Yeah, Anand was with me.
Yeah, I saw the photos.
We ran together.
Yeah. Great. I mean, super presentation. Very, conceptual, and I think it's very important to understand, to know exactly what's going on. And interpretation of PO2, often something, we don't calculate much in neonatology. The ADO2 calculation often, I think in PICU, it is very much well taken up. But in neonatology, a lot of time, people skip doing the calculation, but it's important to know exactly what's happening, the exchange level. Even PA to FI2 ratio also is a good marker. And there are lots of studies prognosticating also using ADO2, especially babies with PPH and severe parenchymal lung disease, even babies with CDH, certain ADO2 levels are kind of markers of preoperative stability and all those things. So yeah, great. Superb. Any questions on this? Everyone saying comments only. Very nice presentations. I think we have covered lots of examples already. So nothing left for me to also add on. Dr. Sridhar, any comment from your side?
Yeah. Excellent presentation, and it takes you back to the medical college days.
Yeah.
So can we start?
I wanted everybody to participate because I was ready with so many examples, but it was not feasible here on a Zoom meeting.
Can you stop sharing the screen so we can see you in full screen?
So I think there is an app, as I think Dr. Itkar, you might be aware, no?
Yeah, Dr. Devpujari
Sir's app is there on ADO2. So I often use that in the NICU, the ABG app and the ADO2 app is actually good to calculate. So either you can.
I make all my assistants to calculate daily.
I think that's good.
Keep on. They are ready with these concepts.
Good.
Dr. Satish app, Dr. Devpujari Deosat, it's called. I think that gives you the calculations as well for most of these. Again, the general principles are well stressed. Unfortunately, all of us are poor in mathematics, Dr. Anant. So
correct. Yeah, we have taken it because we are not very good in mathematics. Yeah, those who are interested, this is the app I was just showing. You can download, and actually, I think what Dr. Itkar said, that's probably the best way. You calculate in your head, it quickly tells you what you're dealing with. But this is how the app actually looks like, which actually takes all the parameters and all the calculations, and it will give you the AADO2 direct number and even interpretation. It's called AADO2 app, and Just search AADO2 and push Dr. Dev Pujari, it will come
Yeah,
up.
that's the same one. DioSat, I think it is.
Yeah.
Uh,
Even he has a
Yes,
ABG app which you can use. ABG app also is very good.
he's one of the faculty on this course as well. And Dr. Anant, can you please stop sharing because the full
Yeah.
screen is ready. Yeah. So very well done, all three of you, and thank you, Kiran. Do you want to have